Good evening, everyone. I would like to welcome you all to another session of webinar for Society of Pediatric Cell Therapy and Transplant SPECT. So this is the 6th meeting we are having, and today is the basic foundation of transplant. That is, to have a successful bone marrow transplant, you need stem cells. So it's all about how to get the stem cells and various techniques and the fine-tuning problems in that. That's all what would be discussed today. And I have a pleasure to introduce today's chairperson. That's Dr. C.P. Raghuram, who is head of the Pediatric Hematology Oncology and Bone Marrow Transplant at Astor's Hospital in Bengaluru. So over to Dr. Raghu to introduce today's speaker and take the session forward. Thank you.
I think today we are going to discuss about a very important but neglected part of the whole bone marrow transplant, which is the collecting the stem cells. First, I would like to invite Dr. Divya Sethia, who is a consultant and head of Department of Transfusion Medicine and Clinical Apheresis, Transplant Immunology and Cellular Therapy at Yashoda Medcity, Indirapuram.
Thank you, sir.
Yeah, I think we can start.
I think first I will start and then
okay, yeah, okay. Then let me introduce the person who doesn't need any introduction. Dr. Satyendra Kateva. He is the pediatric hemato-oncologist and bone marrow transplant specialist and the director of blood and marrow transplant and cellular therapy at Shelby Sanar International Hospital, Gurugram, India. I think it's over to you, Dr. Satyendra.
Thank you, Dr. Raghuram, and good evening, everyone. So as per the promise, we are there, and I promise this is going to be one of the sessions which is going to help you, all the youngsters who are running the bone marrow transplant unit or who wish to have one in their career soon, and all the established one who are now they feel like, going to blood bank is not that much required because the systems are in place. But their fellows need to know all this, because ultimately they will all go out and establish one. So we are going to talk about bone marrow and peripheral stem cell harvesting and then the cryopreservation and the related clinical problems. I will be talking about this forgotten art of bone marrow harvesting, and Dr. Divya Sethia, who is a very dear colleague of mine, is going to take us through the peripheral blood stem cell harvesting and cryopreservation. So that's how we are set. So agenda is very, very simple. We are going to talk about why we need to remember that bone marrow harvest is still important when it comes to its comparison with peripheral blood stem cells. How exactly we do it? What can be done when the dose seems insufficient when we are doing the bone marrow? What should be done when it needs manipulation, when we are doing the bidirectional mismatch or ABO mismatch bone marrow transplants? And now, because it's the world of ruxolitinib, where the GVHD is not that big a problem as it was before, can we rely more onto the PBSC? And I have nothing to disclose. So these are the three sources, guys, we are going to talk about. So the one is the bone marrow, where we collect the cells. The other one is the peripheral blood stem cells, which we do into the blood bank. And the third one is the umbilical cord, which is now almost, because of the many obvious reasons we are not doing it. So bone marrow, hematopoietic, precursor cell harvesting, you need a operation room. It's one of the most well-known method of collecting the stem cells. It has got less chronic GVHD, less autoimmune problems after transplant. And it's most of the time in non-malignant diseases in pediatric, it is still the source of choice. And now the source of choice, or most of the centers are still doing it. Peripheral stem cells is easier to do. You need a good blood bank to do that. The risk of going to the donor to undergo GA is not there, but the problem is it leads to more acute and chronic GVHD. And the other one, the good thing about the PBSC, that it can have a quicker engraftment. So we will see how it's important. Now, this is one paper which is going to tell you from Japan that, so we always talk about that in non-malignant, probably bone marrow is better source. And in malignant, the PBSC is a better source. But that is not true. If you look at this Japanese data, they suggest that, they identified it's a meta-analysis of 7 studies and some 5,368 patients, out of which 3,100 underwent bone marrow transplant and 1,140 underwent PBSCT transplant. So 5-year overall survival and the event-free survival were same. And remember, these are malignant transplant. But if you look at the non-relapse mortality, that means the procedure-related mortality and chronic graft-versus-host disease, they were higher into the PBSC. Now, this is into the malignant. So here they concluded that even in malignant, if it is possible, bone marrow is the better source. So, we all agree about the non-malignant, but even malignant, it's a meta-analysis. Most of the studies are saying it's a good to have bone marrow harvesting. Now, there are some pros and cons about everything. Bone marrow harvesting, the source of choice, particularly benign disease. But just now I said that even in malignant disease, it's a good idea. It leads to safer engraftment, less GVSD, very basic infrastructure. You have a blood bank, you're going to do it. But the issues are that your donor needs to go to the under GA, very small donor. Maybe you might not have a pediatric anesthetist. Small donor, then, two problems are there. How much to take out, and then the PCIS from where we collect it is going to be a problem. Then there is a problem in the bone marrow harvest when you are doing some bidirectional or major mismatches, RBC blood group between the patient and the donor. So then you need to do some manipulation with that. And as we talked about, very small kid, it's very difficult to have it done. So how do we do it? So before we talk about, so this is the bone from where we are going to collect it. This is the anterior superior leg spine. This is the posterior superior leg spine. And we are going to collect it from the posterior superior leg spine. And it usually calcify by 18 months. And target is both the posterior superior leg spine. So this is how the hip bones are there, this one and this one. And how do you put your donor into? So if you put your donor like this is the wrong position. You should never ever be. And you learn this very, very carefully because this is important. But you need to put a small pillow under the ankle position, and then under abdominal, upper abdomen to free the diaphragm. And you take care of the male genitalia if it's a male donor. That is how you place your donor perfectly. This is the wrong position, and you make sure you never put your donor into this. This is how you place the donor, and that is how you start the procedure. Now, the actual procedure is that you need to make sure that your donor has got around 12-13 gram of hemoglobin, but never do it if your donor is having less than 9.5 gram %. And this is particularly important in thalassemia traits, when the donors are thalassemia trait. If they are like 10, 9.5 in between, then you please keep the blood irradiated nuclear, the net tested blood ready once the procedure is done. Then the maximum amount of bone marrow you can take is from the donor is 20 ml per kilo. Do not cross that. There are few papers they have gone up to 25, but do not go there because there can be the significant volume loss, and that can lead to hypotension. Then how do you do it? We are going to tell you, but important is that you do not make the many skin punctures. You just make one significant skin puncture, and then you keep on changing the bone punctures through that same skin puncture. And we'll talk about in a bit. Do not use more than 5 ml syringes. Collect 2 ml, 3 ml, whatever you want to collect. Do not, if you're going to collect by the 10 ml syringe, yes, you can. We have done in few of the patients, but then your bone marrow gets diluted. So 5 ml syringes are a good idea. You can use that. And every time, once you are going inside the bone, so what you do is at the posterior superior iliac spine, you make a skin puncture, and then you let the needle go inside the posterior superior iliac spine. You make sure that the needle is nicely, snugly fit. It is not loose. And then you start extracting the bone marrow, 3 ml, 2 ml. With every time you collect a 2 ml or 3 ml bone marrow, then you make a move of 90 degree of the needle. Remember, the bone marrow harvesting needle edges are beveled. So once you rotate it, now it's facing the other direction. Then after that collection, you again make it another 90 degree, then another 90 degree. So 4 to 5 collections from each bone prick. Then you take it out, then you flush it. And then from the same skin prick, you again make a bone prick again. And that is how you collect it. And now this we have talked about. And then how do you decide that if you're doing okay or not? So then the one thing is that, if you're doing a bone marrow harvest, then once the mid procedure is done. So what is mid procedure? We will talk about it, but it is grossly that you have reached your target collection, half of your target collection you have reached. So you send a sample 2 ml into the EDTA for the TNC or CD34, whatever your unit practice is there. And the another one you send at the end of the procedure to do whatever it is. Target dose of the stem cells are simple. These are 3 to 5 into 10 raised to power 6 for the transplants, if it is CD34 cell target. And you can be very sure that for autologous and allogenic, this target, if you're going to achieve it, it's going to be okay. And TNC is always 2 log more. So 3 to 5 10 raised to power 6 is for the CD34. For TNC, it will be 3 to 5 10 raised to power 8 is the one which we should be focusing at. Post-procedure, this is very, very important. You use bupivacaine. And remember, bupivacaine vials are there it's a very, very commonly used drug with the anesthetist. So you take 5 ml. Each ml has got 5 mg. So 5 ml of bupivacaine, and then you go to same prick. And then wherever you feel like, yes, here we have made some bony pricks, you just inject bupivacaine over there. That take care of the bone post-procedure. And then after a buffering hours of around a couple of hours, then you do a CBC, sodium, potassium, and calcium for sure, just to make sure, because a lot of anticoagulant citrate has been used, and that might lead to a lot of electrolyte disbalance. Now, what you need to do for that is you need to have most of the pediatric patients, either 13 or 15 gauge needle is the one which is going to be there. If it's a small kid, then you might need a 18 gauge needle is also there. You need some 6 to 8 needles. Then you prepare a stock solution of the Haplog. And how do you prepare the Haplog solution? You take 500 ml of normal saline, and then you take a heparin, and you put 5,000 units of heparin into that stock solution. So that makes it like 10:1 heparin. And then all your needle flushing, all your syringes flushing, everything is to be done into that particular container, which you prepare the stock solution in with. Then one dedicated person, when you are collection, you say 2 ml right side, 3 ml left side, 1.5 ml right side. So one person is writing right and left onto the paper, and he keeps on adding the volumes over there. And in between, he keeps on adding the total volume collected. And that is how you understand whether you have reached the mid procedure or not. Collection bag should always have the written name, whether it's a marrow or the peripheral blood, the date and time. And more important is that when you have collected completely, you seal it there, and then you wrap it into the sterile towel, then you transport into the transport bag, and that it goes to the blood bank for the further processing, where they do the quality blood culture and the transfusion transmitted viruses testing and all that. Now, that is how the operation room looks like. Donor in the prone position, which I have told you. And at the foot end of, on the both PSIS, two surgeons stand, which are physician in this. You and one of your senior or junior or the colleague is going to be there. And then at the foot end, there are 3 more tables. Onto the first table, there are empty syringes, then which are like haplogged. Then there are one more side where you put you have collected the bone marrow into the needle, into the syringe, and you have put it over there, which is the blood bank guy is going to use it. And onto the third, there is a small ball is there, which has got 500 ml of normal saline with 5,000 units of heparin. So that is how you're going to use it in the first, second, and third table. And that is how you take out, you put it there, you take the next syringe. And once when do you change the syringe? Whenever you feel like that the suction part of the syringe is gone, then you say throw the syringe. And you keep on saying these things. Do not forget it. Write 2 ml, 3 ml. This is the most crucial thing, just to make sure. And then this was the standard procedures. Nowadays, this is not available. This was the Baxter bone marrow collection bags were there. It used to have one receiver bag, and then it used to have the collection bags. So there used to be anticoagulant in this CPDA, which is cited phosphadextroadenine, and it used to be 6 to 7. So that means if you are going to use 7 ml of bone marrow, then you need 1 ml of CPDA. That is how you decide this. Then you first collect it, the receiver bag, it goes from there into the receiver bag. And once you are done with this, then through this 500 and 200 micron, you pass it on to the smaller collection bags, and that is how you complete it. But this is not available anymore. And even if you try to arrange, it is very, very costly now. This has become 60,000 to 70,000 rupees. So what do you do? So what we are doing right now is we are doing it on the Frigenius bags, which are easily available. They are either 350 bags or 450, and then they have the collection bags of 1 liter as well. You keep the same anticoagulant to bone marrow ratio around 6:7:1. You keep it over there. After collection, now there is no 850 micron filter over here like the Baxter bag. So what you do is, once you've collected your desired, you pass it on through the BT set. That will take care of all your fat and bone spicules and clots. And then finally you shift to 1 bag. Sterile connecting device are attached to it. And then you send it to the blood bank for the required procedures. And that is how you send for the CD34 or TNC. And you also do the blood culture and TTVs. And how do you put it into the bag? So once you are onto the OR table, you open this sterile bag, and here you put in a 3-way under the sterile conditions. So you put in the 3-way, then you put the defined amount of CPDA as per the calculation 7:1, and then whenever your bone marrow harvesting guy is giving you 2 ml or 3 ml, you attach it to the 3-way, and then you open it up, you push it inside, and then you flush the needle, flush the syringe and give it back to the harvesting guy. And then you keep on flushing in and out of this bag so that no clots are formed into this. And that is how you are doing it. It's a lost, art which is now going away because most of the harvest are being done at the PBSC. But we should make sure that we know how to do it. And as per the capacity of bag, we collect it, then we seal it, and then we transport it. Now, this is CD34 cell dose. How do you calculate it? This is for here. Most of the things are very, very simple. And Dr. Divya will be talking about it in more detail. So this I have kept it over here. What if there is a weight disparity? What it means that your patient is like 40 kg and your donor is only 12 kg. So then there is a concept of giving G-primed bone marrow, and it's a small RCT, and it says, yes, if you use G-primed bone marrow, your stem cell dose is okay after 5 days of 10 microgram per kg per day and lower overall GVSD. So they suggest over here from Australia that yes, G-primed bone marrow is a good idea. But one thing is there that with the bone marrow, the complaints like fatigue, pain at donation site, low back pain, difficult walking, they are more with the bone marrow than the peripheral blood. But overall, if there is weight disparity, you can use G-primed bone marrow. Now, here is a consensus statement from COG about the Pediatric Blood and Marrow Transplant Consortium. And they also conclude that risk of GCSF are minimal and benefit of both the donor. They also almost conclude that G-primed bone marrow, there is nothing wrong with it and we can do it. Now, if you see it here in a review article, you see here G-primed bone marrow versus bone marrow, better DFS, less TRM with G-primed bone marrow. So they have concluded that yes, G-primed bone marrow can be done. There is nothing wrong with it. And these are the few more studies which we are going to talk more once we are going to do the panel discussion as well. Now, that is how they conclude G-primed bone marrow for allogenic HSCT. Yes, you need more stem cells. You can use G-primed bone marrow. That's a good idea. So I'll summarize here and hand it over for Dr. Divya Sethia. Bone marrow harvesting is still the best possible donor choice for HPC transplant in pediatric, particularly for non-malignant. But there is data even in malignant which says that it's a good choice. Even if the standard procedure kits are unavailable, we can do it with the routine collection bags which are there into the blood bank. We need to make sure that the sterility is maintained. Plasma and RBC depletions are an additional process that needs to be done very carefully. G-primed bone marrow is a good alternative when it comes to compensate for the weight disparity between the smaller donor and the big recipient. And there should be a policy in place to look at the data and then the audit. And these are my mentors who have taught me the skills of the bone marrow harvesting. And with this, I thank you. And, if you want to chart something, just chart one, choose very smartly, then keep on auditing. And that is how you can build your own program. Thank you very much. With this, I'll now finish the bone marrow harvesting, and Dr. Divya will take on from here for the peripheral blood stem cell harvesting. Thank you.
Thank you, sir. I hope my slides are visible.
Yes, they are.
So without wasting further time, let's move on to the topic. So I've been given the topic of collecting peripheral blood stem cells and how do we cryopreserve them. So I've outlined my presentation under the following heads. First, we'll take a background of peripheral blood stem cells. Then we'll look at the aspects we need to focus on before performing apheresis. What do we need to take care of during apheresis? What do we need to do after apheresis? We'll talk about cryopreservation and storage after that, and then I'll conclude. So, introduction to hematopoietic progenitor cells. So, these cells can be uh, um, obtained from three sources, either the bone marrow or the peripheral blood or through cord. And accordingly, they have been named as HPCM, HPCA, and HPCC. When it is collected by apheresis, it is known as HPCA. Hematopoietic progenitor cells, which are found in peripheral blood, can easily be collected by apheresis, and that makes it a very attractive modality because HPCA are a little mature and therefore you have faster hematopoietic recovery. It is a less invasive procedure as compared to bone marrow, and therefore you don't need to give a general anesthesia. Why it became popular? Because now we know that stem cells can be brought into the peripheral blood. We have sort of mastered the art of mobilization. We have certain advanced apheresis techniques which are available with us. Cryopreservation techniques have also evolved. Early engraftment is always in the interest of the patient. And now we are better equipped at dealing with GVHD, which was a concern with HPCA. Now, whenever we are planning collection by apheresis, there are certain things that you need to focus on before you do apheresis, which includes a transfusion medicine consultation, a proper requisition, mobilization, and consent. On the day of apheresis, you need to take care of the procedure. You need to check whether the patient requires RBC priming, give calcium prophylaxis. There are certain calculations that you need to do, which I'll be talking about later. And then you need to monitor the donor. After apheresis, you need to perform a sampling to do a quality check. You also need to monitor now. You need to check for dose adequacy. You need to manipulate if there are certain indications, and then you need to store and cryopreserve before you infuse the product. I'll be taking you through all these procedures now. So first things first, it is very, very important to know that as per this gazette, which was released in 2020, leukapheresis is now included under the Drug and Cosmetic Act, and leukapheresis, which leads to collection of granulocytes, lymphocytes, peripheral blood stem cells, all requires a license now. So you need to have a license before you proceed for a stem cell harvest by apheresis. So first things first, whenever you're planning for an apheresis, you need to send the patient, the donor, to the transfusion medicine consultant. Why? Because they are the ones who will explain the process of apheresis, the process of mobilization, what will happen to the donor on the day of apheresis. I've seen donors who are actually told that it will be just like blood donation, and when they see the cell separator, they get scared and they have a lot of anxiety. What will happen to me? So it is very important that when we are planning for apheresis, we need to prime the family and introduce the family to the cell separator. Then a transfusion medicine person will also assess for ABO incompatibility, whether it is a major mismatch, whether it's a minor mismatch, or it's a bidirectional, and what all steps need to be taken in such incompatibilities. They will ensure that all investigations are requested before apheresis and evaluate the donor and recipient for disparity, because this will also guide the mobilization and the process of apheresis. Then we will also evaluate for venous access. So for elder donors, adult donors, if the veins are suitable, we can give an option of peripheral access to the donor. However, if the donor is the donor does not understand the procedure, it is difficult for a peripheral venous access, and therefore we would prefer a central venous access. We can also, this consultation will make sure that we schedule an appointment for apheresis, because this particular cell separator has a function of collecting your platelets. It has a function of doing plasmapheresis. You can also do a therapeutic plasma exchange, a red cell exchange, and these procedures might be planned. So sending this consultation makes sure that an appointment has been scheduled. And we also assess the donor for fitness, the most important being the psychological and emotional fitness. We assess whether the donor has understood the procedure and whether they are ready to undergo mobilization and apheresis or not. The next thing is a requisition and an informed consent. This is very, very important. As per the Drug and Cosmetic Act, we are now required to keep a record of all the requests that we receive for any therapeutic procedures. So, therefore, this is just a sample request. You can draft your own requisition form, but it should include that the information of the donor, the recipient, the indication for which this stem cell harvesting is being planned, the target dose that you require for the transplant, any special storage requirements, any manipulation that might be required, and a tentative date of harvest. Similarly, when you take an informed consent, make sure that details of the procedure, expected outcome, risks of the procedure, alternatives of the procedure, the risk of no treatment, and any high risk if required should be mentioned on the form, and the consent should be signed by the doctor taking the consent, the donor who is giving the consent, and a witness also. Now, when we talk of mobilization, it is more like mining gold in a mine. So we can think of the mine as the bone marrow. Mobilization is the process of mining, and our stem cells are the gold. So what we are trying to do is we are trying to take out these stem cells from the marrow into the peripheral blood. What we are actually trying to do is increase the number of circulating stem cells to ensure an adequate collection, which is important for transplantation. Now, any sort of heavy pre-treatment and previous radiation are all factors which can actually make your donor a poor mobilizer. So, a thorough history of what all the donor has been through, donor or patient has been through, should be taken. Now, there are three agents primarily by which we can do mobilization: granulocyte colony stimulating factor, plerixafor, and chemotherapy-based mobilization. GCSF is usually started 4 to 5 days before apheresis at a dose of 5 to 10 microgram per kg per day. Plerixafor is usually given 11 hours before apheresis, and chemomobilization is given before GCSF. There is also a new agent on the block, which is motixafortide. This is a CXCR4 antagonist with long receptor occupancy, which has been approved for multiple myeloma only at present. Because safety trials for pediatric population have still not been done, but we might see this drug coming up for pediatric population in the near future also. Now, once we started mobilizing the individual, how do we know whether this is adequate or not? So this adequacy can be checked by two things. The gold standard being CD34 positive cell count by flow cytometry, and there is absolutely no substitute for this test. However, if you do not have a facility for performing this test, then you can rely on certain parameters which are available on your CBC. Now, how do you correlate these CBC parameters with the CD34 positive cell count, which you obtain via flow cytometry, considering that your CD34 positive cell count is actually the gold standard? So to understand this, there is this CBC that I've actually displayed here from a mobilized donor. The WBC count you can see here is 35,900. The mononuclear cell count is 6,400, whereas the CD34 positive cell count obtained by flow cytometry is 39 cells per microliter. Now, how do you correlate these findings? It is actually a little confusing. Let me simplify it for you. So when you look at the WBC count, it just gives you an initial estimate of circulating hematopoietic progenitor cells. This can only be used as a first approximation on day 4 to guide any additional intervention, whether you want to give plerixafor or not. There is this 1% rule which says that your CD34 positive cell count will be roughly 1% of your total WBC count. And this is okay if your donor or patient is mobilizing well. However, if your patient is not mobilizing well, it is a poor mobilizer, then this rule will actually lead to overestimation of the CD34 positive cell count. And then what will happen is you will have a poor collection at the end of the procedure. So it is very important to understand that this is only for a rough estimate. It does not correlate well with the flow cytometric CD34 positive cell count. Moving on to the next parameter, that is the mononuclear cell count. So what is mononuclear cell count? You calculate your monocytes and lymphocytes, and that gives you your mononuclear cell count. It is more reliable, relevant, and practical as compared to your WBC count. Why? Because the out of all the WBCs, the CD34 positive fraction is very, very small. But when you talk about MNCs, this fraction is something actually. So this MNC count shows a strong correlation between MNC and CD34 positive cells, especially when the donor is being mobilized. However, this is also not accurate. There are other parameters also that have been explored that can be obtained from a CBC. However, not many of them will actually give you a true estimate, and therefore I would like to repeat the statement here that there is actually no substitute for flow cytometry. Now, once you know that mobilization has started to happen, when is the correct time to actually start an apheresis? Or in simpler words, what is the cutoff below which I would not prefer starting apheresis? So again, it can be dependent on your CBC parameters or your CD34 positive cell count. If you're looking at your CBC, a WBC count in peripheral blood when exceeds more than 2,000 to 4,000 per microliter is gives you an indication to start apheresis. And MNC more than 10 to 15 into 10 to the power 3 per microliter gives you an indication to start apheresis. However, this is not very accurate and this should be understood. The next thing that we can rely on is CD34 positive cell count. So anybody who has a cell count of less than 20 is not a very good mobilizer. But I would absolutely not start apheresis if the count is less than 10, because this would not actually lead to me collecting in a product which has a good yield. Now, moving on to the vascular access. So I discussed it briefly before that we have two kinds of access, peripheral and central. For peripheral access, what is required for apheresis is usually a 16-17 gauge needle. And because this requires two different access, one for inlet and one for return, so you need to place two needles in the different arms. Now, your donor should be muscular enough to actually have these good veins for these needles to be inserted. And because the procedure is long in nature, therefore, it is very uncomfortable for the donor. So what we do for pediatric cases, we actually prefer central, and for peripheral, for adults, we give a choice between peripheral and central to the donor themselves. If they feel comfortable enough to go ahead with peripheral, only then do we proceed for peripheral. Otherwise, we go for central vascular access. Now, what we actually need for apheresis is a tunnel double lumen central venous catheter, which is stiff to avoid collapse under the negative draw pressure of the apheresis equipment. And there should be a port offset to minimize the recirculation. And that is why we prefer an HD catheter, because it supports the high flow rates of apheresis. It has a dual lumen design, and the donor remains comfortable, and it is ideal for all donors who do not have a good peripheral venous access. We do not prefer using tunneled Hickman catheters and PICC lines. The inlet flow rate that is required for this particular venous access is roughly 1 to 2 ml per kg per minute. And if at all you have any confusion, you can always consult your transfusion medicine specialist. Now, this is a table that I've put up for you to help you actually decide what French size to choose of the double lumen central venous catheter in case of your pediatric patients. So your body size or weight actually dictates the French size, and this might be of use to you. So this was all that we did before apheresis. Now we'll move on to the D-Day. That is, what all do we have to do on the day of apheresis? Now, first of all, the timing. So because we have a short window of stem cells being in peripheral blood, time your apheresis correctly. Try and start early, somewhere between 8 to 9 a.m. If your GCSF has been given at 6 a.m., your Plerixafor has been given at 11 p.m. probably, and for healthy donors, then you would want to plan your apheresis at 8 to 9 a.m. in the morning. Now, I've written here that Plerixafor at 6 a.m. in poor mobilizers. So some studies have actually come up with this fact that in poor mobilizers, the kinetics of Plerixafor is very different from what it is in healthy donors. And therefore, the peak effect comes between 4 to 6 hours of giving Plerixafor. And therefore, if you have a predicted poor mobilizer, you can give them Plerixafor at 6 a.m. in the morning. Now, if we look at the available cell separators that we have primarily, we have actually 4, but I'll leave out the 4th one because it is sort of obsolete. We don't use it anymore. So the current practice is using these 3 cell separators, that is Optia, Amicus, or Comtech. All 3 are centrifugation-based cell separators, and all 3 have a similar extracorporeal volume of roughly 180, 190 ml, and all have a good efficiency to collect your hematopoietic progenitor cells. Now, when I say that this is cell separator is based on centrifugation, what I mean is your components of the blood will be separated out on the basis of specific gravity. So your red cell will, having the highest specific gravity, will settle down, and your plasma, having the least specific gravity, will stay on the top. And your stem cells will be somewhere around the layer where your lymphocytes are. Now, Optia, the first equipment that I had showed, uses a collection preference tool. This is the collection preference tool that is that they use. So they have colors of the Buffy, and they say that the middle one is actually the one where you'll get your maximum amount of mononuclear cells. So all you have to do is match the color, and that is the layer that you're going to collect. When we talk of Amicus, so Amicus has this screen where you can enter your MNC offset volume, RBC offset volume, MNC collection set point. And what you are basically trying to do here is, so in this particular picture, you will see that plasma is on your right. The blue cells that we are seeing are your mononuclear cells, and the green cells that you are seeing are your granulocytes. So granulocytes are in the lower compartment, and plasma is upwards, and you are collecting the middle layer, which has your mononuclear cells. So if you set your RBC offset between the granulocytes and your mononuclear cells, you can harvest your MNCs. The third equipment that we have is Comtech. So Comtech is like a cyclical based collection where you have 4 phases in the cycle. The first phase will include collection of the blood. It will centrifuge the blood. In the second phase, it will try to condense the layers, that is the plasma, that is the buffy and the red cells. In the third phase, it will actually take out the plasma, and in the fourth phase, you will actually collect the buffy coat or the mononuclear cells. Now, when we talk of performing apheresis for a pediatric patient, we need to understand that these cell separators were actually designed for adults. They are not designed for pediatric patients. And when you look at them, the extracorporeal volume, even with the sophisticated equipment, is somewhere around 180 to 200 ml. This is this extracorporeal volume can cause hemodynamic instability in a small volume pediatric donor, and therefore we need to use priming. So what are the indications for using priming? If your extracorporeal volume is more than 15% of the patient's estimated total blood volume, if the body weight of the individual is less than 25 kgs, if the hematocrit is less than 20%, or the hemoglobin is less than 8 gram per deciliter, or the total blood volume is just less than 1000 ml, all of this is an indication for a prime. So priming can be done using various agents such as plasma and albumin or RBC, but we prefer using RBC for priming. What kind of RBCs do we use? We use leukodepleted, irradiated, cross-match compatible, and preferably RHKL matched units for priming. Now, whenever you are priming with red cells, it is important to understand that you are giving red cells to the donor, and therefore to prevent volume overload, do not perform reinfusion. Coming to the anticoagulant that we use during the procedure. So the most common anticoagulant that we use is acid citrate dextrose, and ACD-A is the one that we prefer. So ACD-B is also present, ACD-C is there, but we use ACD-A only, which has 3% citrate. The anticoagulant to blood ratio ranges from 1:10 to 1:14. Now, citrate acts by chelating calcium, therefore ionized calcium levels drop during the procedure, and the patient or donor might have symptoms of hypocalcemia because of this calcium binding effect of citrate, but particularly in pediatric population where the hepatic metabolism of citrate is low. And in children in general, the milder symptoms might be missed, which actually would lead to us appreciating the symptoms only when they are severe. So whenever you are giving acid citrate dextrose, do monitor your ionized calcium and do give calcium prophylaxis. Another anticoagulant that can be used is heparin. However, heparin alone is not preferred. It is usually, even if it is given, it is usually given in combination with acid citrate dextrose to decrease the dose of the citrate that is being infused. Why don't we prefer heparin? Because heparin has a higher number of bleeding complications. It is associated with thrombocytopenia, and monitoring of anticoagulation with heparin is tricky. So when we mentioned that acid citrate dextrose decreases the ionized calcium, so we need to maintain ionized calcium levels, and for this we actually give continuous IV calcium gluconate infusion. However, please do not confuse calcium gluconate with calcium chloride. We need to have separate protocols even if you are using calcium chloride. Ideally, we do not prefer giving calcium chloride. However, so there was this phase in UK where calcium gluconate was not available, and that is why they had to use calcium chloride, and then they developed protocols for using calcium chloride. So even if you have to use calcium chloride, make sure that you have a protocol in place in your department. And if at all your donor has symptoms of hypocalcemia which are not responsive to calcium, then we need to consider hypomagnesemia also. Now, whenever we are performing apheresis, it is very important that we have a stable interface. What do I mean by interface? So, whenever you centrifuge your cells, the RBCs settle down and then they become like a bed for puffy coat to or WBCs to settle on top of that bed. If we do not have this stable interface, what will happen is that the cells will get mixed. And whenever you're collecting from this particular mixture of cells, you will not have a good product. So you need to have a stable interface, and for that it is very important that your inlet flow rate should be steady throughout the procedure. What I mean to say is it should not keep on fluctuating. So, whenever you're dealing with a pediatric donor, then you need to understand that this is a stressful event for the child, and therefore, explanation of the procedure to the child and the attendant is important. It is preferable to have a parent or an attendant to be present around the donor during collection. Mobile phones or television to watch cartoon films is there so that you can keep the child distracted or engaged. And if at all the child is absolutely uncooperative and all of these measures fail, only then do we recommend giving mild sedation. Otherwise, we don't. And this is absolutely important if you want to have a stable interface in the procedure, which will actually impact the yield of your apheresis product. Now, there are certain adverse events that can happen, and you should be prepared for these adverse events. There are basically 4 kinds of adverse events: citrate-related, vasovagal reactions, venous access related, or mobilization related. I will only focus on your citrate-related adverse events, which can be classified into mild, moderate, and severe categories. Milder ones usually include the paresthesias, lightheadedness, headaches, shivering. This is all mild. But whenever you're doing a pediatric harvest, your child will not be able to tell you all these things. And that is why usually citrate toxicity is detected late in children. Hence, calcium prophylaxis is all the more important when a pediatric harvest is being done. The moderate adverse events of citrate include nausea, vomiting, abdominal cramps, hypotension, tetany, and severe ones would include cardiac arrhythmias and seizures. Now, there are some calculations that we do in apheresis, and I'll quickly take you through these calculations. The first one being blood volume estimation in an individual. So, there is something known as the Nadler's formula that we use, which is based on your gender, height, and weight. Uh, However, your Gilcher's rule also takes into account the body surface area. So, Gilcher's rule can also be used, which actually says that your obese, thin, and muscular individuals have different blood volume in terms of ml per kg body weight. And then you can also use this approximate blood volume estimation in ml per kg, which says that the premature infant at birth has probably 90 to 105 ml per kg. A term newborn will have 80 to 90 ml per kg. Children more than 3 months will have 70 to 75 ml per kg of blood. And then adult males will have 70 ml per kg, whereas females will have 65 ml per kg. Now, how do you know how much volume you have to process during the procedure? So for this, we need to understand that there is a standard leukapheresis and then there is a large volume apheresis. So for a standard volume apheresis, you usually process 1 to 3 blood volumes. What does this mean? So if an individual has a blood volume of 4000 ml, so we are processing 4000 to 12,000 ml, 1 to 3 blood volumes. A large volume apheresis is something where you process more than 3 blood volumes, usually 3 to 6 blood volumes. But usually in practice, whenever we start harvest, 3.5 to 4 is what we do to in one particular session. The next is predicting your CD34 positive cell dose. Now, in the morning, you have a pre-apheresis CD34 positive cell count of 50 per microliter in hand. And you are supposedly thinking of processing 3 blood volumes. So first you calculate what is the blood volume of the individual. So supposedly this is an adult male weighing 60 kgs. You multiply 70 ml per kg into 60, you get a blood volume of 4200 ml. And you are processing 3 times the blood volume, which makes it 12,600 ml. If the collection efficiency of your cell separator is supposedly 70%, and the recipient weight is 40 kgs. So what do you actually do? You multiply the pre-apheresis CD34 positive cell count into the volume that you are processing, into the collection efficiency of your cell separator, into 1000 divided by the weight of the recipient, and this will give you a predicted CD34 positive dose that at the end of apheresis, when I've actually processed 3 blood volumes, I might get a target dose of 11 million per kg. This is what we do at the end of apheresis. So once you're done with apheresis, you have an absolute CD34 positive cell count of the apheresis product in hand. So if that count is supposedly 1000 per microliter and your product volume that you've collected by apheresis is 200 ml and your body weight of the recipient is 40 kgs, then your total CD34 positive cell dose is that cell count obtained by flow cytometry multiplied the product volume multiplied by 1000 divided by recipient weight, which gives you a total dose of 5 million per kg. Now, if at all you do not have CD34 positive cell estimation facility at your center and you want to calculate your dose with MNC, how do you calculate it? You look at the CBC, you look at the absolute lymphocyte count, absolute monocyte count, add it, and then you multiply it by the volume and then divide it by recipient weight. So okay, you get 5 into 10 to the power 8 per kg. Now, you've understood the calculations. How do we know when to end apheresis? Your protocol can be different. Some centers choose to decide the endpoint of apheresis as the whole blood processed in liters. So you can decide that I will not go beyond 12 liters or 15 liters. Or you can choose the total blood volumes that we studied, like a standard blood volume of 1 to 3 and a large volume leukapheresis of 3 to 6. Then you can decide the endpoint based on your runtime. So you can decide that I will not go beyond 4 hours or 5 hours when I'm doing apheresis, or based on the collected product volume in ml. So some centers choose to collect a fixed volume of apheresis product, which might be like 300 or 400 ml. And the most appropriate parameter that we can use is the dose collected, which can be estimated by performing a mid CD34 count. So what we do in a mid CD34 count is that at exactly mid procedure, we take a sample from the product and send it for CD34 cell count estimation. And if it usually comes out, the report comes to us in 45 minutes to 1 hour. And on the basis of on the basis of this report, we can actually decide that this much is the dose that I've collected till now. So how much more will I need? How much more volume will I need? And on the basis of that, you can terminate the procedure. So why I'm saying this is the most appropriate method is because neither will you under collect nor will you over collect. In over collection, you would discard the product, which is not good. And in under collection, you might want to do a procedure the next day, and that is also not good. So your mid CD34 positive cell count tells you when exactly to terminate the procedure. Now, once we are done with apheresis, all we do is wait for the quality check of the cryopreserved product. So what do we do when we say quality control of the harvested product? First is enumeration of the CD34 positive cell count by flow cytometry. Next is assessing for microbial contamination, and then there are functional assays. Now, functional assays include colony forming units or ATP-based assays, and this might not be performed everywhere, but a microbial contamination and a check for CD34 positive cells by flow cytometry is something that we should do. How do you monitor your donor immediately after collection? So, because inevitably there will be loss of platelets and red cells during the collection, along with your mononuclear cells, you need to monitor the peripheral blood counts of the donor. And this is more important in autologous harvest, where the patient might have a lower cell count before starting apheresis, and then you might want to transfuse if necessary. The next thing that I would want to monitor is ionized calcium. In addition to ionized calcium, I would say that other electrolytes are also important. However, ionized calcium is utmost importance. The third thing is watch for vasovagal reactions. So these are most common immediately after apheresis. So whenever you are actually ending apheresis, give very clear instructions to the donor to not get up from the bed immediately after apheresis. Tell them to gradually mobilize, and that too under observation. The fourth thing is once you have your end apheresis CD34 positive cell counts, then you can decide to remove the catheter or plan for another procedure the next day. And the fifth is ensure hydration, but do not fluid overload, thinking that they have lost a lot of fluid. The next thing is graft manipulation. So whenever there is an ABO incompatible transplant, there are three scenarios. Either it is a major ABO incompatible transplant or minor or bidirectional. When it is major ABO incompatible transplant, what we actually tend to do is either do a red cell depletion of the product or do a plasma exchange in the recipient. Red cell depletion of the product is cumbersome and may lead to your stem cell loss. A plasma exchange in the recipient, if at all it is significant, the titer is significant and the contamination is also significant, a plasma exchange in the recipient is more feasible. If you talk of minor ABO incompatibility, you can either do plasma depletion of the product or a red cell exchange in the recipient. However, plasma depletion of the product is more feasible to do. So if your titers actually indicate that you need to do a plasma depletion, you can do plasma depletion. It might lead to minimal cell loss. But then if it is absolutely necessary, then you can go ahead with plasma depletion. In bidirectional ABOI, you can do both, and with the help of sophisticated apheresis device, actually it is possible to keep a check on the plasma collected in the product and the red cells collected in the product. So if at all we see that there is a major ABO incompatibility, what we would try to do is keep the hematocrit less than 3 to 5%. This is what our actual target is. We do not try and exceed this hematocrit so that the red cell contamination on the product is less. And if it is a minor ABO incompatibility, we try and keep the plasma content in the product less. There are other graft manipulation techniques such as depletion and enrichment, which might be necessary. Now, coming to storage, once it is collected, we need to store it. So before storage, it is very important that you label the product appropriately. A product will never tell you, I am from which donor. So only if the label is properly stuck on that particular bag will you be properly able to identify to which recipient it belongs to. So therefore, labeling is very, very important. The product should be stored at 2 to 6 degrees, ideally for no more than 48 hours. However, there are various studies that have been published which say, and from Indian literature also, which say that you can even keep it up to 4 days without loss in viability. Again, this is only for auto, and this needs to be validated at your own center if you're planning to do it. If you want to keep the product beyond 48 hours, you cannot ideally store it at 4 degrees, and you therefore need to cryopreserve it. Cryopreservation is an integral part of hematopoietic stem cell transplantation, especially autologous hematopoietic stem cell transplants, and you need to have trained personnel and aseptic precautions for you to be able to perform it. Now, when we talk of cryopreservation, what is so different about cryopreservation? When you keep your cells at sub-zero temperatures, so they have an injury in the form of either intracellular ice crystal formation, or they get dehydrated and then they die. So there are certain cryoprotectants that need to be introduced in this system when you are actually proceeding for cryopreservation. Before we move on to cryoprotectants, there are two things. We either do a dump freezing or a controlled rate freezing. Dump freezing is done with less equipment and minimal infrastructure, and it is very viable and suitable for low resource settings. Controlled rate freezing is done with liquid nitrogen, which might be expensive. If you
Can
look
we wrap it up, because there's
Yeah,
another panel
Divya,
discussion.
we can do
so-
this with the panel discussion, right? It's already, time is less, so we can do it later with them.
all right, sir.
So just wrap up.
Sir, I'll just take the infusion of a cryopreserved product. So there are certain things you need to keep in mind. Always perform a clerical check, and it should be bedside thawing and immediate infusion of the product. And an immediate sampling needs to be done if you want to check for viability. Because if you keep the sample and you send it for viability later, the viability will come down. When we thaw it, we take the thaw bath at the bedside, and we do that procedure at bedside only, and we take samples from there and immediately send them for testing. And these are two methods by which you can check for viability: trypan blue and flow cytometry. There are a couple of DMSO toxicities that are reported, which can be reduced by DMSO washing, but then that will lead to cell loss also. So in conclusion, a transfusion medicine physician will actually help you go through all the procedures like apheresis, collection of stem cells with good yield and purity, mobilization, minimizing risk of infection, your transfusion support, cell processing, quality control, special products that might be required during transplant, and minimizing complications. Thank you.
Thank you, madam. That was, I think, wonderful talk by both Dr. Satyendra Kateva and Dr. Divya.